3 weeks later, he came back and the lights were back on. In fact, his wife was so excited about this that she actually came in. This guy really required a different type of assessment and analysis that just usually doesn't get done in the primary care clinic. Oftentimes, I find, particularly if it's not one of these chronic lifelong depressions, but it sort of occurs at some point in life, that there's either something situational going on that could be addressed, or there's something biochemically going on that has to be addressed. Thank you for joining me as we explore frontiers in integrative health. I'm Dr. Dan Monti. Welcome. So I just saw this really interesting 57-year-old guy who came into my office, and he had received a diagnosis of depression from his primary care doctor. And he really was experiencing a decrease in his mood, his energy level. He was having a hard time functioning in his work and his job. This was new onset. He hadn't had depression before in his life. So this is somebody who really liked his job. He liked to work. He owned his own business. He had a shop that he cultivated over many years and really grew this business. He enjoyed interacting with the customers. But in the last few months, that wasn't the case. He had a hard time getting up in the morning. He wasn't enjoying being there like he usually did. He felt tired and lethargic when he was there. His sleep started to get poor, and then you had this negative vicious cycle of feeling tired and then having poor sleep. In addition, he just didn't have the energy levels in an overall sense. He also was feeling like he just didn't want to exercise anymore. He also found that when he went home at night, because he just didn't like the way he was feeling, he started to have a glass of wine, and then maybe a second glass of wine. So doing this compounds the negative mood. These are all the kinds of things that we have to address from a lifestyle perspective, because what people often do when they're depressed is engage in behaviors that actually makes them more depressed. So part of the intervention isn't just to address the biochemical changes or the hormonal dysregulation, but also to look at the person's lifestyle and try to get them back on track to a healthier, less depressing lifestyle. His primary care doctor put him on one of the common antidepressants, but it didn't really do the trick. I mean, one thing we have to understand is that primary care doctors, their offices are set up to put out fires. They don't have the luxury to dig deep. They don't have the luxury to look at the embers after the fire has been put out. So we need them doing what they're doing. They're great at what they're doing. But when there's a chronic problem, sometimes that in-depth assessment and evaluation doesn't occur. It's just the way that it is. So in the case of this patient, his primary care doctor just going to an antidepressant, this is common practice, but it's also one of the reasons that depression is so poorly treated in this country. The rates for recovery are so low because not everybody's depression is the same. This person's depression, it might be very different than this person's, everything from the etiology to how the depression manifests itself. So this guy really required a different type of assessment and analysis that just usually doesn't get done in the primary care clinic. Now, when someone comes into the office with a story like this, and it's new onset later in life, I often wonder, is there something missing? Is there something that the person is depleted in some way that's causing this depression? Because depression is complex and it's multifactorial. So yes, sometimes it's trauma-related, or sometimes somebody has a genetic biological depression, but neither seem to be the case in this guy's situation. So we decided to dig deeper and look further. One of the things we found from doing blood work is that he had an exceedingly low testosterone level, so much so it was equivalent to that of an 80-year-old man's. And a lot of the symptoms he was having was consistent with something we call hypogonadism, or a very low testosterone level. Some people function fine with a low testosterone level as they get older, but when that fall happens precipitously, which is what I suspected happened with him because of the way the symptoms presented themselves, it can be jolting, and it can make a huge difference to actually supplement the testosterone in as safe and bioidentical way as possible. We did that. But in addition, his diet wasn't so great, and What people often do as the mood starts to go down is reach for things they consider comfort foods. Those comfort foods usually are inflammatory, like have a lot of bad fat, processed foods, high sugar, the types of things that actually wear the system down. So you already have a challenged system in this depression that then gets more challenged and more pushed in a depressive state. And this is a common thing that people do. They actually, without knowing it, perpetuate the negative vicious cycle. So fried foods, saturated fats, things that are in snack foods are all examples of the kind of fats that are inflammatory. Whereas the anti-inflammatory fats are the ones we often hear about, like omega-3 fats that are in certain plants and also in aquatic fish. And some of our testing suggested that he was something called a hypomethylator, that he wasn't methylating his B vitamins well. So we also gave him methylated B vitamins and some other dietary recommendations. That combination really made a big difference. 3 weeks later, he came back and the lights were back on. He stopped taking the antidepressant. We weaned him off of it very carefully, of course, and he's functioning back like his old self again. In fact, his wife was so excited about this that she actually came in and noticed that she had become a little sluggish herself. It was a different set of dietary principles we applied with her. But again, the two of them working together, that made a huge difference too, because they cleaned up what was in the house, what they were eating, and also increased their activity level together. And at the end of the day, we had a much happier couple. For all of the people out there that become depressed, they go on an antidepressant, and it doesn't do the trick, or doesn't do the trick sufficiently, there's hope. And oftentimes, I find, particularly if it's not one of these chronic lifelong depressions, but it sort of occurs at some point in life, that there's either something situational going on that could be addressed, and or there's something biochemically going on that has to be addressed. In the case of this patient, we had vitamin imbalances, nutritional deficiency, and also a real dysregulation of his hormonal system. Addressing those things, looking at other hormones such as thyroid, all of that can make a big difference then in the outcome of somebody who's presenting with symptoms of depression. If somebody comes to me and says, I've become depressed and the first line treatments just aren't doing it for me, here's what I usually do. First, I take a very careful history and make sure that there's not something situationally going on. And if there is, I address that. But in addition, I look closely at the person's biochemistry, everything from their metabolism, their vitamin levels, including vitamin D, the B vitamins. I get a sense of whether they're methylating correctly. There's genetic tests for that. So there's a whole armamentarium of labs that I look at that aren't considered routine, and often people just don't get. In addition, I want to make sure that things like dietary factors that affect inflammation but also affect mood are being looked at. So for example, fatty acids. Oftentimes in the typical Western diet, there is consumption of a lot of fat, but a lot of the wrong fat. And an overconsumption of inflammatory fat and not enough of that good anti-inflammatory fat can actually affect mood. And when you intervene with some of these dietary changes, including fats, you can make a big difference in how the person feels. Then another level that I often look at is activity level, because there's good data out there that once people get into that slump, their activity level goes down, and that becomes a negative vicious cycle. And what you want to do is get the person moving again, because exercise can actually help lift the person out of the depression. You have to take a multi-pronged approach to depression because there's often lots of things contributing to that low mood. If patients are proactive when they see their primary care doctor, they can get some of the things that I always look at. For example, if it's a middle-aged male with a new onset depression, ask for testosterone levels. Oftentimes they're not drawn unless the person requests them, and the physician might say, there might be a copay, I'm not sure if your insurance will cover it. But sometimes it's worth that extra expense to know if testosterone is an issue. Also, vitamin D levels are very easy to get, but oftentimes they're not drawn. And a low vitamin D level can be an increased risk for depression as well. So there are things that people can do to get a little bit more from the primary care visit, and they should ask for those things. I'm Dr. Dan Monti. Until next time, be well.